You're listening to Astonishing Healthcare, the podcast hosted by Judy Health, focusing on the biggest issues affecting healthcare consumers, benefits plan sponsors, and health plans. We're covering how things truly work or don't in the U.S. healthcare system and pharmaceutical supply chain, and we're doing it in an astonishingly efficient way.
Hello, and thank you for joining us for another episode of the Astonishing Healthcare Podcast. This is Justin Vanieri, your host and Senior Director of Communications at Judy Health, and I'm excited to welcome Jason Barreto back to the podcast for a government programs episode. Jason was last on, it was too long ago actually. It was episode 11, Navigating CMS's M3P, which is no longer called that, right? It's MPPP.
MPPP, yes.
PDE and other regulatory changes. Since then, we've had Jess and Joseph on the show a couple of times to talk about some Medicaid, sort of macro and other drug pricing trend issues. And you co-led a webinar for us since then. So it's not like there's been radio silence, but I am excited to catch up with you today. And I think congrats are in order, right? You were promoted to Senior Vice President since recording that episode from VP, and your team's growing pretty rapidly.
Yes, we've been growing in all sorts of directions.
It's great. So thanks for coming back on the show.
Thank you for having me. It was great to be on.
Just super quick, in case anybody's new to the show, hasn't met you before, heard your background, give us 30 seconds on your background and what you did before you joined us, Jason.
Sure. I've spent my entire career in managed care, mainly on the pharmacy side of the house, managing PBMs for health plans. And so this is actually my first foray into the PBM space and working with health plans on the other side of the table. So I use a lot of my background to navigate various new requirements, our relationships with our clients, and any nuances that health plans bring to a PBM.
Okay, so demand for transparent and aligned commercial pharmacy benefits partners has been up and to the right, as the old Wall Street saying goes. And you, as you just described, work with health plans primarily. What's been going on the health plan side of the house?
Yeah, I mean, I'm seeing the same thing. Every conversation I have, and every RFP that we receive is demanding transparency. And, when I use the word transparency, I'm not just referring to our pricing and rebate model, right? I'm referring to Capital RX as an entity, our processes, our workflows, everything. We're very transparent with our clients. And that's really important to me because, again, my background, my experience, my career is being on the health plan side of things. And so when I was a client and I requested information from a legacy PBM in order to do what's required of me by the government, whether it's federal government or state government, as a contract holder, you're obligated to oversee any delegated vendors. And so a lot of time I would receive, hey, that's proprietary. And so it's very challenging for me to monitor, for me to oversee those downstream entities and, meet my obligation, my contractual obligation. And so what we've done here at Cap RX is take a transparent approach to, again, not just the pricing and the rebate modeling, but how we do business as a whole. And so we work with our clients when it comes to delegation oversight, audits, or any inquiries they may have. And we're transparent with them about what it is that they're seeing and how we got there, and provide them as much information as necessary in order to make them feel comfortable with what we're doing on their behalf.
Got it. I think in general, just understanding how people make money and what their incentives are, and trying to bring alignment to these relationships is a big trend heading into the new year here.
Yeah, I mean, it's pretty interesting. One of the common questions I'm seeing in the RFPs around transparency is like, how is that impacting your DIR reporting ever since, rules change? And so for folks that don't know, in addition to claims that you have to submit to the government, you also have to submit financial reporting to the government, known as DIR, direct and indirect remuneration. And so that information has to be created and submitted every year to CMS in addition to claims. And the change in CMS requirements in 2024 seem to have had a huge impact on legacy PBMs, which is why the question continues to come up. But for Capital RX, it had no bearing on our operations, on our financials, on anything, because again, we are a transparent PBM. So our pricing model, our rebates, everything that's set up with our networks on their paper, they're paper meaning contracts, right? They're really nothing for us to report because we're not doing any type of clawbacks when we make a payment, because whatever we paid at point of sale is what we charge the client. And that's it. That's essentially the long and short of it. And so I love having these types of conversations with prospects, with clients, because it's pretty eye-opening to them and it just shows our value. And now as Judy Health, we will continue to be a transparent entity, right? We will continue to bring transparency to the industry and provide our clients with that level of insight.
Yeah, that's awesome. And that makes a ton of sense. Like you're saying, those are very logical expectation, I think, for prospective clients to have of their vendors. And, in our old, and I can't believe it's old now, blog series we worked on together way back, you explained how meeting the intent of regulations and flexibility or configurability are so important, along with alignment, of course. Can you provide some updates on what we're working on, what you're working on what health plans are dealing with, or as it relates to some of the things we've seen, MPPP or the IRA come to mind?
Yeah, I mean, the IRA was a huge piece of legislation in 2022. We've implemented most of it since. For 2026, the last big piece was, we love acronyms in our industry, right? So MFP, maximum fair prices. And so this is a huge piece that we had of the legislation that we had to pull through for 1/1/26. And essentially what it is CMS took top 10 drugs and they negotiated directly with manufacturers to set a price for those drugs. And so you have things like Jardiance, Januvia, Stelara on that list, Enbrel, Novolog. So you have some pretty impactful drugs on that list that have a much better list price because CMS negotiated these deals, right? And so essentially the way it works is CMS set these prices, they publish a list, and we load it into Judy. Judy will then look at what is the lowest price in the system. Is it going to be our ingredient costs? Is it going to be the MFP price? And depending on which is going to be cheaper, Judy will pick that price and apply it to the claim, and the member will reap the benefits of this new program, for lack of a better term. But essentially, it's an annual drug list that will come out, and it'll get kind of evaluated each year against, again, what are the top high cost drugs and, for that plan year. And so CMS has drafted a list for 27. So we already know what 27 will look like more or less. And so this year is 10 drugs, next year it'll be 15, and it'll continue to progress in following years. It could go up to 20 drugs in 28.
The prices on those are just TBD, based on whatever the negotiations spit out of and
for 26 is already set. So we already know what those prices are, but for future prices, it's kind of TBD. There's another factor that comes into just not what the utilization looked like at the time they did the analysis, but they used a consumer price index to adjust for inflation.
Yeah, I remember looking at the first 10 and thinking, those looked like pretty good prices on some of those drugs. They were pretty solid compared to the bubbly prices that are out there in the market, right?
Yeah, I mean, the prices are pretty insane when you compare it to the manufacturer's list price. Obviously, we don't ever pay list price. We pay a negotiated version of that. But even these newly negotiated prices by CMS, at least some of the ones I looked at, are better than what I've seen in industry. So all in all, it looks like the members will benefit from this new requirement.
And then how about on the MPPP front? Anything to report there? Any updates? I think that program kind of got off to a little bit of a slow start and communication around it.
Yeah, I mean, CMS initially estimated about 6% of the population will qualify and be part of this program, but nationally about 0.5% of the population has decided to participate in some shape or form with the program. And so what CMS has done to help with the participation is they're allowing members to automatically renew year over year. It seemed like initially that they were going to require health plans to terminate everyone at the end of each plan year and start everyone anew, meaning they would have to opt in again. But they changed course and are allowing members to automatically roll over year, which is great for adoption, right? It's one less barrier that they have to face with this program.
That seems smart. And then if the experience is good for any of those members, maybe through a little bit of word of mouth or otherwise could help.
Exactly.
And then, with your example earlier, you alluded to some of the flexibility just in how the system actually works. One thing we talked about a lot is customizations, configurability, et cetera, how flexible Judy is. Of the things we've quote unquote turned on in Judy that are safe to share, can you give us an example or two of a problem or problems that you've been able to solve using the system that might have been more challenging in your previous life over the
Oh,
last
yeah.
12, 18 months?
It was actually a great conversation that I had with a new client that we're implementing for 1/1/26 when we're talking about their benefit and how we were going to set it up in the system. They started to ask questions around D-SNPs. So D-SNPs are dual special needs programs. These are members who qualify for both Medicare, Medicaid. Usually the sickest of the sick, the poorest of the poor. So you want to make sure that whatever you have set up for them is working as intended. And so in my prior life and in this client's current life, the way their D-SNP is set up in the system is it's two of everything. So you have two lines of eligibility, two groups, two networks, two benefit configurations. And it's because the way that the system administers the benefit is it processes one claim through Medicare as the primary and then another claim. So that's right, two claims for one transaction for one prescription. You'll see that second transaction for Medicaid as secondary to Medicare. So when I came to CapRx, that was one of the problems I wanted to solve. I hated the two transaction method for D-SNPs. It was very, very challenging for us at the health plan to manage and marry those two records back together, et cetera, et cetera. And so what we've implemented is we've been able to keep one benefit, one network, one line of eligibility, one claim, which has been a tremendous help for our clients that have D-SNPs in their financial reporting and clinical reporting and everything else.
Very cool. And aside from just what sounds like a lot of duplicative reporting and challenges combining data, how much time are we talking here? Just curious.
Think about having to maintain everything twice. One of the issues that I used to constantly run into was sometimes we would implement a Medicare network on the primary and a Medicaid network on the secondary because someone saw Medicaid and thought, oh, it needs to be the Medicaid network. And so when the member would go to the pharmacy, the claim would pay on the Medicare and then reject in Medicaid if the networks weren't the same. So you avoid things like that using our methodology. Is just even with benefit configuration, sometimes someone would forget to activate a plan code or something on the other side. Usually the Medicaid side was the one that suffered because it was kind of a second thought. And so having it all in one place in one system on one claim eliminates all that hassle.
Awesome. Okay. And then I'm curious, we just released a special episode, and I'm going to put you on the spot here. I'm sorry, but I got to do it. In that, a handful of our folks and external guests shared, particularly astonishing things they saw, read, thought were interesting in 2025 that left a mark of some sort. Could be positive, negative, just has to be safe to share. Any news or events or observations over the last year that struck you as particularly interesting that you'd want to share, call attention to?
The only thing that was really surprising to me was how much we talked about GLP-1s this year. I understand that it was something that no one really expected as far as how cultural it would become. GLP-1s are in the kind of average American vernacular now. Like everyone knows what a GLP-1 is. And you can't say that for most drugs. It's kind of crazy that class of drugs has become so popular and, just pop culture in general. It's just out there so much that everyone and anyone knows what they are and even knows what they're priced at. It's pretty crazy.
It is amazing. Exchange of information there around these. And to think, Sarah Zadi said it a while back, she saw it kind of start in like little social circles and on Instagram, and it took off like wildfire, I guess.
Yeah.
So last question for you today. Thank you so much for taking the time. What should health plan executives be watching for or planning for this year? If you look out 12 months, what are the big things that you think are, key to pay attention to and work with their vendors to get right for their plans and their members?
Yeah, I think one of the big things for me this year is audit readiness CMS has recently changed their approach to Medicare program audits. So for me, it's going to be interesting to see what they focus on, especially now that they've extended their audit period and they've changed the way they scoring mechanism for health plans. And I'm sure they're not done with their changes to how they audit health plans. So it'll be an interesting year to see how all that plays out and if that drives any changes on the PBM side of things.
Got it. Jason, thank you so much for taking the time today. Pleasure having you back in the studio, and I look forward to staying in touch, seeing how things evolve over 2026.
Thanks for having me. You have a good rest of your day.
Thank you for listening to Astonishing Healthcare. Head over to judy.health and visit the Insights section for show notes and other relevant content. If you like this episode, be sure to subscribe so you don't miss the next one. And definitely share the link to this show with your network. Have a great rest of your day.